Thank you very much. Good afternoon, ladies and gentlemen. It was my great pleasure to be at this meeting. I'm Nicol Ferrier from Newcastle, and I'm also representing the British Association of Psychopharmacology at this meeting. So I'm going to talk about some recent advances in the neurobiology and treatment of bipolar disorder, and this will just be a short description of one or two of the main highlights from recent research on that topic. So first of all, I'll be mentioning a couple of drugs, so I need to give my declaration of interest, but I don't think there's any conflicts of interest. So what I want to start with is the neurobiology of bipolar disorder, and focus particularly on cognition. So there's been a very exciting development in bipolar disorder, which is the recognition that patients with bipolar disorder, even when they're well, even when their mood is normal, have cognitive deficits. And this is very important because it's important for the patients. It causes them a lot of problems and probably delays and impairs their return to work. But in addition, it's also an insight as to what's going on in the brain. And this slide shows the amount of research that's been done on this topic over the last 20 years. So a huge rise in the number of papers on this particular topic. This slide shows a meta-analysis of all that data, particularly focusing on euthymic patients, whose mood is normal. They're neither high nor low when these tests are done. And down the bottom are the effect sizes for these various domains of cognitive function. So you can see there's quite a widespread deficit of varying size, really very little in the way of IQ change, very different from schizophrenia, but a lot of problems with memory. But the key things that stand out are executive function, particularly to do with planning and monitoring of processes, and also processing speed, the speed at which people process things, which is linked to attention. Now, most people now believe that, in fact, underlying all these cognitive deficits in bipolar disorder is probably one main deficit, which is in attention and processing speed. We've done quite a lot of research on this topic. For example, here's a study in which we looked at the continuous performance task of bipolar patients. And what we find is that bipolar patients initially perform quite well on this task, but as the demands on the attentional system rise, difficulties emerge. And the particular problem is with context maintenance. So what's thought to be the central problem in bipolar disorder is the attentional control, or the executive control of the attentional system. So people have now been proposing that this may be what is called a cognitive endophenotype of this disorder. And if you look at a number of studies in this area, it's interesting to note that if you look at, for example, processing speed, that it falls. This is healthy controls here compared with patients. But in the middle are unaffected first-degree relatives. And there in the middle, they have some degree of processing speed and mild cognitive abnormalities. And so it's suggested that this is a genetic pattern that's inherited, and those patients didn't inherit enough genes to become patients. They remain unaffected, but they still show some abnormalities. So an increasing amount of data suggesting that the control, processing speed control of executive function is a central deficit. Now, on a related theme, there's been a lot of interesting new research done on the genes in bipolar disorder. And this is one of the studies that was done looking in a large number of patients for particular genes. And two particular genes stood out in this study, the ANC3 and the CACNAC1 in bipolar disorder. And these are genes which are related to signaling and cell processing. What's happened since the finding of these two particular genes in bipolar disorder is people have investigated the neuropsychological consequences of having this gene and looked at what happens with people who are homozygous for it and have two copies of it. So in this particular study, people were looking at the CACNAC genotype on attentional networks and noted that those people who were homozygous, in fact, had reduced speed for alerting, increased speed for orientating in terms of their attentional function. So the gene itself seems to be linked to attention. The gene is also involved in emotional processing, and so those people who are homozygous for the gene have change in their brain response to emotional pictures that they're seeing. And these are all normal subjects, but just people who happen to have a double dose of the gene. And a similar thing has been found with the ANC3 gene, that other gene that's high risk in bipolar disorder, and initial evidence for selectivity to signal detection during sustained attention. So it seems that it's possible that some of the key genes that are abnormal in bipolar disorder may be leading to this cognitive deficit that we've been detecting in our euthymic patients. So that's a very interesting development of neurobiology. Another one is the understanding now that we can see white matter changes in the brain in bipolar disorder. This is quite an old slide showing white matter hyperintensities in the brain of a patient with bipolar disorder. Now, normally we might see these in subjects who are elderly, particularly those with hypertension or strokes, but this was in a young patient, a 23-year-old patient, who had changes in white matter hyperintensities in the frontal lobe of the brain, and really quite abnormal for someone of her age. And this is now the most consistent finding in bipolar disorder. It's very rare in healthy controls. It's present very early in the condition, just after the first significant episode. And people have demonstrated, just like they did for cognitive function, that there's a gradation in the amount of white matter change found on scans from healthy subjects at the bottom here, through unaffected relatives, through patients with bipolar 2, to patients with bipolar 1 without psychosis, to patients with bipolar 1 with psychosis. There's a gradient in the increase of burden of white matter hyperintensities in those subjects, suggesting also a genetic component related to the development of these white matter problems. Now that's using a simple MRI. More people have now moved on to use DTI, diffusion tensor imaging, to look at these white matter changes. And we did this a number of years ago in collaboration with a group in Edinburgh. So these are results from bipolar patients looking at the integrity of the white matter. And what we demonstrated was changes in the white matter, subtle deficits in the frontal areas particularly, in terms of diffusivity, a measure of integration of white matter, and also in another measure in more posterior parts of the brain as well as the frontal parts of the brain. Now, since that time, there's been a wide variety of DTI studies, and this slide shows a meta-analysis of those white matter changes are found in bipolar disorder. There's basically two areas where the white matter is particularly abnormal in bipolar disorder. One is in the hippocampal area, which is presumably relating to memory and attention and the integration of emotion with memory, and another in the cingulate, particularly related to emotional processing. So what we have clearly is neuropsychological dysfunction in bipolar disorder. We're now establishing the link with white matter lesions. The next question that we have to fill in, and this picture up on the right here, this person up on the right here is my colleague Hamish McAllister-Williams, who's giving the next talk, who's very puzzled about this, but is going to solve this problem of how these particular abnormalities, neuropsychological dysfunction and white matter lesions, link to the key problems in bipolar disorder, that is unstable mood, and how also they link to over or under expressed genes. But we now have a fruitful area, I think, to dissect in bipolar disorder that might tell us a lot about the underlying neurobiology. But nothing in psychiatry is simple, and what we've also demonstrated is that some of the cognitive deficit seems to relate not to the genes of the patient, nor to their neurobiological substrate, but to something about their upbringing. In this particular study, we looked at childhood trauma scores. Now, a lot of bipolar patients will tell you that they had adversity in childhood, in particular problems with relating to their parents. And if you look at these abnormalities, we find that they're much greater than in the normal population using this particular childhood trauma scale, but also that these high levels of emotional and physical abuse, particularly emotional neglect in childhood, links to the cognitive abnormality. So like many things in psychiatry, it's biological, related to the white matter and to genes, but it's also linked to the environment the child was brought up in. Now, so that's the main abnormalities we think are present in neuropsychology in the brain, but some of it may be dissectable in different ways and might be due to different causes. One of the abnormalities you find in bipolar disorder is spatial working memory. And people in this task have to touch at one of these red squares, and behind some of the red squares are hidden blue tokens, which they then move down to the store on the right there. They then have to go back and look for more tokens, and what bipolar patients tend to do is that they tend to lose the place when doing this and go back to a red box they've tried before. So they have errors, spatial working memory errors during this task. Now, another abnormality we find in patients is raised cortisol, and this is even when euthymic. They have high levels of the stress hormone cortisol in the blood, even when euthymic. And here in red are bipolar patients compared with controls. Now, this is interesting because it's been known for quite a long time that high level steroids can cause changes in spatial working memory. And here's a results of a study done where hydrocortisone was given to normal subjects. And there was an increased number of errors, spatial working errors, on those subjects given hydrocortisone. So it raises the question of whether the spatial working memory errors in bipolar disorder are due to the high levels of steroids. So we decided to test this by giving a drug which blocks. It's a glucocorticoid receptor antagonist, and it blocks the effects of steroids on the brain. And when we did this in a group of bipolar patients, we found that there was an improvement in their spatial working memory, initially at 14 days after the drug was given, but there was a change and there was quite an improvement in spatial working memory, the reduction in the number of errors, about 5 or 6 weeks after the delivery of this particular drug. So it seemed to reset the system and allow for increased improvement. So the memory problems we see in patients are partly due to their environment, partly due to genes, partly due to the white matter change, but also linked probably to the high levels of steroids that those patients are exposed to. And there's been an increasing interest in this cognitive signal in bipolar disorder, and this is the results of a study in Barcelona done by Edward Vieta. And what he's done is he's looked at cognitive remediation of bipolar patients, and he's compared that with treatment as usual and also with psychoeducation. And he found that you got big improvements in function of patients, how they were functioning in the real world when they were given cognitive remediation. So this is a very exciting method. We might be able to help patients with these difficulties in the future. So moving quickly on to treatment and changes in treatment for bipolar patients. We know that to treat bipolar patients properly, you need to give a combination of pharmacological interventions, psychosocial interventions, and also involve the family. And I just want to highlight one or two developments in each of these areas. First of all, service delivery. There's now quite good research evidence to suggest that if you give patients a lot of support with their problems, particularly psychosocial support, enhanced psychological or social support, then those patients will do well, and then particularly it will protect against relapse. And this shows data from the bipolar guidelines of the BAP when we reviewed this area in 2009. And since that time, the evidence has got stronger that doing psychosocial support and also giving someone a consistent person to whom they can talk to produces much better outcomes. This is important because we know up in the top right here is a number of admissions for bipolar disorder in the UK across the last 10 years. And so we know that despite improvements in treatment, there's still a lot of people being admitted and it's not really changed. So we need to do something else to help our patients other than just give them drugs. And as I say, we have data for psychosocial treatments that may help. This shows the results of a study done in America where they did something called collaborative care. And there was a person, a nurse, who patients could contact to get help. And the nurse also contacted them to check they'd taken medication, that they were doing their different tasks of psychosocial treatment. And what it showed was that there was an improvement up here in the top right-hand corner. There's an improvement in the number of days manic in those patients who had the collaborative care compared with those who had treatment as usual. So there was a reduction over the time in the amount of symptoms the bipolar patients had. And what they demonstrated in this second study, that was probably related to adherence, that by doing this involvement with the patient, there was an improvement in adherence in a number of the subgroups in this patient trial. Another psychosocial development that's very interesting is using early warning signs, so identifying those symptoms that happen in patients just before they become unwell. And although they vary across all sorts of patients, within each individual patient there's an individual signature of when they're about to relapse. And if that can be identified and a strategy put in place to do something about it, for example, avoiding alcohol, getting more sleep, taking some more antipsychotic, then all these studies here, there's a whole series of studies, have shown that you can reduce the number of manic episodes that the patient has. So combining the collaborative care with some early warning signs intervention can make significant improvements for our patients. What about pharmacology? Well, This shows, I think, one of the most exciting studies done where quetiapine was looked in a large number of bipolar patients over quite a period of time. And quetiapine produced benefits in protecting the patients against mania on the left-hand side and against depression. It also showed very good effects of lithium in this particular study, but one of the largest studies done in lithium. So we have two drugs here that could protect against relapse in both poles of the illness. But of course nothing is straightforward in psychiatry, and we know that these kind of drugs like quetiapine can cause major problems with weight gain. This is actually Gwyneth Paltrow from a movie a number of years ago showing what a good actress she is. But anyway, this kind of weight gain occurs in quite a lot of our patients with drugs like quetiapine and olanzapine. So what's exciting is the development of the new drug, lorazepam. This is the data showing it's effective in bipolar depression, both as monotherapy and as co-therapy along with another mood stabilizer. So the same sort of efficacy you'll find for quetiapine. But the interesting thing about lorazepam is that it's relatively neutral in terms of weight gain and any change in triglycerides and glucose. Now this is licensed in the USA but not yet in Europe, and we don't yet have enough long-term data, but it's an exciting development for the future to improve the treatment of our patients. And if you put all these things together, you can actually produce overall care. This is a study from Copenhagen, where the patients either had standard care and outpatients across Copenhagen or went to a mood disorder clinic, where they did collaborative care, early warning, signs intervention, and also gave the best up-to-date pharmacology. And this shows the outcome of those patients, time to readmission over the next 6 years. And you can see that attending the mood disorder clinic and getting these special things improved outcome. So I hope I've convinced you that things are improving in terms of the neurobiology of bipolar disorder. We now have some important clues and also in treatment. But it is important that, first of all, I don't kid myself, and secondly, I don't kid you. There's a lot still unknown and a lot still to do. And the best way forward is to take the advice of one of my heroes from the 1960s, Frank Zappa, who said that the mind is like a parachute. It doesn't work if it's not open. Thank you very much for your attention. Thank you. Thank you.